you. Thank you, Professor Carlson and Bensiker, for moderating. Thank you for being here early this morning. I'm going to try to give an update on double bundle ACL reconstruction. I'm going to go relatively quickly through this, and I hope it's of interest to you. Remember that the most important reason for failures of ACL reconstruction are our surgical technical failures, most important because that's what we have most control over as surgeons. And remember that most of the ACL reconstructions probably done around the world are done by surgeons who do fewer than 20 per year. This will become important later in the talk. I think to frame the discussion of double bundle, the two questions that are important are whether in the short term this particular procedure could potentially increase technical inconsistency, complication rates, and failures in general orthopedic practices. As opposed to the second question, which is equally important, whether this technique could decrease revision rates and improve outcomes in the long term. So the surgical success might improve in the best case scenario, but what if the complication rates also increased? This is fundamentally a question of risk-reward in surgery, right? As we assess the situation, anybody who's a golfer knows that sometimes taking that risk isn't worth the reward. And it is a function of the golfer and that person's skill and judgment and experience the same way as for a surgeon. And I think this is important as we talk about this new procedure compared to our standards. I think there's something fundamental about why we still struggle with the ACL, and this is a problem we've been dealing with for a while. Why are we still having trouble? I think the anatomy arthroscopically is still somewhat confusing. This may seem obvious, but it wasn't to me for many years. And let me explain why. The traditional teaching, at least when I was training, was to go for the, quote, over-the-top position at the back of the notch and put your tunnel a couple of millimeters in front of that position. So that was called that because of the over-the-top guides that were used for 2-incision ACL reconstructions. And this is an example from a relatively recent publication showing where the pin would come out high in the notch and what we would consider to be back in the notch. And then we developed transtibial guides, which drove the tunnels wherever the guide went. There wasn't much leeway. But these instruments drove the position of our tunnels. And this is an example from one of my cases, which at the time I would have been very proud of. You can see, hopefully the pointer, you can see the tunnel is way back there. It's close to the over-the-top position. I thought that that was very posterior. But that's not posterior, actually. And if you take a sagittal section, this is from Kondo's work, and look at it from the side, anterior and posterior. Now, this is very obvious, but anterior is up on the screen, posterior is back. And what we're really looking at is the proximal distal dimension as we're looking in the notch. So there's a difference between what we see on our gross anatomy and what we see with our arthroscopy, which is done with the knee flexed. So if I were to ask whether this is the posterior position, it's not. This is actually posterior within the knee as you're looking arthroscopically. This is a very important reason, I think, why we've gotten kind of confused over the years. Remember also that there's this landmark, which is a ridge which separates the two bundles. That's a useful landmark for doing single bundle reconstruction. I'll come back to this later. The tibial side is also a little bit confusing. These are two articles from Japan published around the same time. This is where they indicate on their drawings the posterolateral bundle would be obviously different. And from a surgical perspective, we have to understand what we're trying to accomplish when we're doing these surgeries. And so the anatomy is still a little bit confusing. We also simplify the anatomy as a double bundle, and of course it's really not. It's actually thousands of collagen bundles. They twist, they reorganize, so it's a complex anatomy. There's also a larger cross-sectional area at the footprints than in the middle of the ACL, and we don't reconstruct any of that when we do any of our procedures. So the double bundle anatomic procedure is actually a little bit of a misnomer, in fact. So why would we consider switching or moving to a double bundle reconstruction? Well, it's logical, and it's been also supported in the laboratory, that a sagittal tunnel from tibia to femur doesn't control rotation of the tibiofemoral joint as well as a more oblique graft position. And this is intuitive, and has been supported. So there's less tibiofemoral rotation with a more oblique than compared to a sagittal tunnel. How can we achieve that? Well, we can make an oblique tibial tunnel. That's been described. There are some techniques using flexible pins and reamers, or you can go through the medial portal to get to a lower position. This is an example schematically of how a tibial tunnel could be drilled versus a transportal approach for the femoral tunnel that would allow a lower position. And Leo Pincheski taught me this at one of the meetings that he was speaking at years ago, and I adopted this in my practice, using a medial portal to make the femoral tunnel quite a few years ago. And then this is a drawing from his work. It's not difficult to do. It requires some hyperflexion of the knee, but he reported on his findings at 10 years with really, really good results, 97% normal or near normal. Now, this is a very important question as we're framing double bundle reconstruction, because the gold standard for comparison is the key. What are we comparing the new technique against? And we'll come back to that. So as we talk about evidence-based medicine, we need to focus on the control group and whether that control group is relevant to the comparison for the double bundle. There's a study that sort of supported this concept. This is both single bundle techniques at a more sagittal position and a more oblique position. And the point from this study that I wanted to demonstrate was that there were better outcomes, the same kinds of outcomes as we look at double bundle, looking at a lower femoral tunnel than a higher femoral tunnel. This is with single bundle reconstructions. It emphasizes again the point of a relevant control group as we look at these new procedures. So back to the question, why would we consider a double bundle reconstruction? Well, there is probably better reproduction of anatomy with a double bundle. We know that the posterolateral bundle controls tibial rotation with knee extension, which is the corresponding maneuver to our pivot shift maneuver when we do the physical examination. It would be nice to control that. So the laboratory studies are interesting and actually moderately compelling, but the pivot shift exam is very subjective and potentially affected by the observer's bias, in other words, the surgeon's bias, and it's very hard to quantify that actually the tibiofemoral rotation, although there are some techniques that have been described, as you can see there. So now let's move to the clinical evidence, because that's really what this talk was supposed to address, evidence-based medicine. And I'm going to go through these studies rather quickly, and then at the end I'm going to try to roll this up into a summary for everybody. So this was a study published in 2007, comparing double bundle and single bundle. The double bundle reconstructions took a little longer. This is a theme that is repeated. And I think it's pretty obvious why. It would take a bit longer. Relatively short follow-up with a few more failures in the single bundle technique. Oops. The pivot shift results were slightly better in the double bundle, but of importance, there were no abnormal pivot shifts in either group. So the results were pretty good in both of these surgical procedures. But this is an important and interesting quote from that study published in 2007. I'll read it for you. Because there are more tunnels, more grafts, and more fixations, the double bundle technique is recommended only for the hands of the most experienced ACL surgeons. This is a subsequent study comparing 24 double bundle and 25 single bundle, and this was a comparison of the single bundle technique with a low portal. This is, I think, a relevant comparison group. Minimum 2-year follow-up, nice study. Pivot shift exams may be slightly different, favoring the double bundle, but I don't think 1+ pivot is that bad for our reconstruction results. No difference between the groups in the KT1000 or the IKDC. And another quote from this study, this was only 2008, a couple of years ago. Due to this, we believe that even if double bundle technique is advocated to obtain superior results, this technique should only be used by experienced surgeons. So they're recognizing it's a touch more difficult. A randomized prospective study from 2008, 35 double bundle and 35 single bundle, average follow-up less than 2 years, a little longer with the surgery. But the important findings were that there was slightly less laxity in the double bundle group, 0.6 millimeters, statistically significant, maybe clinically significant, but no difference in subjective outcomes or functional knee scores in this study. Yagi published a study in 2009, 60 patients that were randomized into 3 different reconstruction techniques, one of them double bundle, the other 2 were single bundle using hamstrings. The follow-up was interesting. At 1 year after surgery, they measured rotation when they took out the tibial screw, so the time of anesthesia, and used some 3D electromagnetic sensors to measure that. The clinical outcome differences were negligible. And during the pivot shift maneuver with the accelerometers that they were using, there was a little less rotation in the double bundle group than either single bundle method. There was an interesting study by Tsuda that compared single bundle to double bundle, but it's a bit of a confusing comparison because there are two different graft choices that were used. No difference in laxity or IKDC or pivot shift between the groups, but I would recommend this study for you because there's really a good table that summarizes the prior published literature that is very concise and useful for you. Aglietti, just in 2010, compared 35 single bundle, 35 double bundle, double incision surgery in both of these groups, 2-year follow-up. This is a picture from that paper showing the jig that they used and the bundle positions. And I thought I would show this again. That ridge in between the two bundles is a useful landmark arthroscopically. This is where I try to put my single bundle reconstructions. This is a picture showing the hardware that was used for that particular article. And this is a busy slide, I'm sorry about that, but the important thing is that the visual analog scores were slightly better in the double bundle. They thought there were more normal knees based upon IKDC final scores in the double bundle. I think the failure differences are negligible. The KT1000 was better in the double bundle than in the single bundle. That was statistically significant, and they thought there was fewer pivot glide in the double bundle. And this is from the Chinese Medical Journal from 2009, comparing single bundle and double bundle reconstructions with very short follow-up. No differences in functional outcomes in that particular study. Another paper from Kanaya, very small numbers, 13 low single bundle and 13 double bundle. This is a picture from their study, and this was interesting because they used a torque device to measure tibiofemoral rotation, and no intraoperative differences in AP or rotational stability, but this was a low single bundle reconstruction comparison. Very important to recognize that. I'm going to wrap up with the data, I think, pretty soon here. Sastra, a small number of horizontal single bundle and double bundle reconstructions for comparison. Notice this pin. This is the way to go through the medial portal, a low medial portal, and then up for the femoral tunnel. No outcome difference between these groups in this particular study from 2010. So, I know I went fast. How do you then roll up this clinical information to some sort of an evidence-based approach? Well, one of the ways to do it is with meta-analysis. And this is also confusing, unfortunately, because Meredith published a study in 2008 and concluded that there was no difference in KT1000 or pivot shift according to the best available evidence, not all of it, the best available evidence at that time. And Dr. Carlson's group here, the subsequent year, published a paper, and I think the important conclusion from that paper was that there was probably better rotational control with the double bundle reconstruction. So two meta-analyses with slightly different perspectives on these reconstructions. So I'm going to give you what I think is the bottom line from all of this work. Some of the randomized controlled studies, I think, suggest that the double bundle has better control of the pivot shift than the single bundle reconstruction. There's some evidence to support that statement, but I think it's really critical to look at the control groups and make sure that the single bundle comparisons are good comparisons. Is it a gold technique? Few differences in clinical outcomes or patient-based subjective ratings of single bundle and double bundle. There's a lot of variation between the studies in tunnel position, graft selection, constructs, so it's very hard to generalize across these studies. We know for sure that the implant costs and surgical time are greater, if that matters very much. There's no literature about complication rates or clinical outcomes for double bundle in a general community setting. And the long-term studies are just not available yet in terms of long-term graft failure, meniscus pathology, arthrosis, and functional outcomes. So my recommendations for anybody who is trying to decide, understand the anatomy, go back to the basic gross anatomy and compare it to arthroscopy so you can reproduce that. Consider the risk-reward for these procedures and do what's best in your hands. I think that the surgeon ultimately has to decide what he or she can pull off and do best, and I appreciate your time. Thank you very much. Stay up here? Okay.
Thank you, Robert. Now we are going to the questions from the floor. I expect there will be many. Questions to Robert?
I can start with the discussion. Just a statement concerning the differences between the study that Samuelson and co-workers did in my group and Meredith. There's 1 year between, so Meredith, he assessed 4 different studies and we had 8. So that's probably the difference. And if you look at the double versus single bundle, you are very right that the study designs are different, so it's very difficult to draw any firm conclusions. But you must compare the same thing. So if double bundle is on one side of the comparison, then the single bundle reconstruction must be done with a modern so-called anatomic single bundle reconstruction with a low portal. So if you are comparing with a transtibial or high portal, we are not really making justice of the comparison. Any comment on that?
I think you're absolutely right. The gold standard probably for a single bundle is a lower tunnel position on the clock face, and when you look at those studies specifically, the results are less compelling, I think, for the double bundle. So I would expect that a meta-analysis in a year or 2 from now might come up with some different conclusions. We'll see.
Yeah. Another thing is that all of the studies are small. You know, all of the studies are, say, 20, 30, 40 patients in each group, and this is a usual thing, that all clinical studies are too small. They may be power calculated from the beginning, but then we have a dropout and a couple of problems, and then we end up with a study that doesn't really give conclusions because they are underpowered. Yeah. So what we really need is how large study?
I haven't calculated the power, but you're right. It's easier if you find a difference with a small number of patients, but it's hard to be confident if there's no difference. And I suspect that these studies with 15 or 20 patients per group are way underpowered. I think you're right.
Yes, question? Please stand and use the microphone, please. Yeah.
Hi, good morning. It's Ayman Abid from Egypt. Thank you very much for your very nice presentation. Do you think, looking at a single bundle versus double bundle now, do you think that most of the surgeons should shift from transtibial technique to a medial portal technique for achieving a good low femoral tunnel, even in a single bundle?
Yeah, I'm not sure. It depends upon the graft. You can achieve a low femoral tunnel by making the medial tibial obliquity, but it makes the tunnel relatively short, which is a problem for patellar tendon grafts. So if you're using a hamstring graft, it's a little more forgiving. And then there are some other techniques with curved guides. But once you learn that transmedial portal technique, it's really pretty easy to do. I've been doing it for quite a while, so it's not a hard thing to train. What concerns me more is with the double bundle in the general community setting, whether we're going to see in a few years, maybe 5 years, problems with revisions, complications. And we just don't have those reports yet from the community setting. Those will be difficult revisions, I think.
Actually, I would like to comment on that. I'm also a journal editor, and I actually received just a couple of weeks ago the first paper I've seen on a small series of complications and revisions and surgery. So it will be published quite soon, but that's interesting. That's the first paper I've seen that really discusses the problems, the surgical technique of double bundle.
We'll wait to see that published. That's great.
Yeah. There's a gentleman.
Yeah, Steve Avila from Lake Tahoe, California, and Madrid, Spain. And in Madrid, we do over 100 cruciates every week, and we take care of the elite level soccer players. If you for some technical points, when you do your cruciate and you go to that to your femoral insertion, look at the femoral insertion as you just look at it and study the femoral insertion. It's much lower than as Rob showed us. The superior portion has almost no value, to be honest with you, and you almost have to go, if you're going to use a bone, through the anteromedial portal, and you just flex the knee really more than 90 degrees. But Freddie Fu makes a point that if you have if you look at the footprint and then you measure the footprint, if your footprint is less than 14 millimeters, then he feels single bundle is absolutely adequate. And this is about a week ago I spoke to Freddie. If you are greater than 14 millimeters of footprint, then Freddie suggests that that a double bundle might be more adequate, and there is really no proof, but he's intending to prove that. So I would urge everybody not to go transtibial unless you can really get to that low position, and I can't. And
Nobody can.
One of the things that Freddie, I think, has emphasized, and it's a valid point, is that the perception of the origin anatomy is different if the arthroscope is in the typical lateral position versus more medial or through the tendon. And I think that's valid. Looking at it from different angles helps us understand the anatomy
I
better.
would urge people to try an anteromedial portal, and I would also urge that when you look at that, when you dissect out and before you make your tunnel, look at the footprint, learn the footprint of the normal femoral condyle in a flex knee position from just a pure technical point of view.